Sorry about the wait. Okay, so today we're going to talk about multicystic dysplastic kidney. I'm going to start the presentation with a case. This is patient GF, a 34-year-old G1P0. She's at 20 weeks and 1 day and presents for her anatomy ultrasound. Her past medical history is significant for asthma, hypertension not on medication, obesity with a BMI of 30, past surgicals, wisdom teeth extraction, family history, hypertension, diabetes, thyroid disease, colon cancer, no significant social history, on prenatal vitamin, low-dose aspirin for to decrease risk of preeclampsia, and then albuterol PRN. Her genetic screening was low risk fetal cell-free DNA. And as we're going through the anatomy, this is the first thing we see when we go to a transverse view of the fetal abdomen to evaluate the kidneys. We see right-sided pyelectasis. And then this is the left kidney. As you can tell, it has a very multicystic appearance to it.
Can you show us the multiple cysts so that everybody who's on? Yeah.
Is my pointer pointing in the right spot? Okay. This is a sagittal view of that left kidney. Again, you're seeing kidney and you're seeing multiple cysts.
Go back to, yeah, stay here. Keely, how would you describe these cysts?
I would say that they are more peripherally located than centrally. They're certainly anechoic, and we do put color on. There's no flow to the cysts. I don't know if I think that's my next slide.
How do you comment on the size?
I would say that the size is variable.
Exactly. And that's a very important characteristic for the disorder that that she's discussing.
And this is color flow Doppler, obviously no color flow to these cysts. And then this is just a coronal view. You're seeing the left side and the right side, as well as a normal appearing bladder. Of note, she did also have a normal AFI. Interestingly enough, the patient had a consult yesterday at CHOP, and I spoke with the provider late yesterday evening. We don't have any formal report yet, but they agreed that they also felt that the left kidney was consistent with multicystic dysplastic kidney, and agreed that there was right-sided pyelectasis. However, interestingly enough, they also saw a cystic mass posterior to the bladder, and it was really hard to discern, is this part of the GU system? Is this a ovarian cyst? Like it was very hard for them to discern. But when I look back at this coronal image, because of course I went back and looked at all of our images to try to see what they were seeing that we didn't see at the time. And I'm wondering if maybe this is what, I don't know. This was the closest thing I could get to anything close to the bladder that was cystic. But
it was behind the bladder, they said?
They did. She said mostly posterior to the bladder. She didn't tell me the size. And again, we don't have a report yet, but this all happened yesterday. But I'm really interested to continue to follow her, and she is going to continue to follow with us as well as CHOP, and we're going to kind of coordinate. The attending was wonderful and said this is a really great case, and she wanted the patient to continue care here as well. But they do plan to do an MRI, and they will go from there. Okay, so that is the case that kind of inspired this presentation today. When we are talking about approaching the urinary tract, you want to focus on the number of kidneys that you're seeing, the location of the kidneys. Are they in the renal fossa? Are they in the pelvis? The size of the kidneys, are they increased or decreased in size? We're using a maximal length in the sagittal plane. This is a, I think we have this hanging up in the ultrasound unit. I'm pretty sure it's the one that we use, but it's a very well-established chart to refer to as far as kidney size based on gestational age. Looking at echogenicity of the kidneys, hypoechoic, are they hyperechoic? Are we seeing any anechoic structures like we did in this case? If so, are they renal cysts? Is it hydronephrosis? Are we seeing a normal bladder? Are we seeing normal amniotic fluid? And if we're seeing normal amniotic fluid, this is the best predictor of normal kidney function. Look at the adrenals if you can, and genitalia. So when we talk about, in general, congenital cystic disease, there are multiple ways you can kind of subclassify these cystic findings, but the one I found to be most helpful was just kind of separating them into hereditary disorders and non-hereditary. And so obviously when we're talking about hereditary disorders, we're thinking autosomal recessive polycystic kidney disease, autosomal dominant polycystic kidney disease, hepatocyte nuclear factor 1 beta nephropathy, kidney cysts seen with syndromes. There are a number of syndromes, hereditary syndromes, and I list a few of them. And we're going to go at the end of toward the end of the presentation, we're actually going to go over these briefly just to kind of nail down our differential. And then when we're talking about non-hereditary causes of cystic kidney disease, multicystic dysplastic kidney is at the top of the list, and that's what we're going to be reviewing today. Obstructive cystic kidney dysplasia, kidney cystic tumors, and then you can have simple or complex kidney cysts. And then just of note, again, we'll kind of get into it in more detail, but the ciliopathies comprise the most common hereditary etiology for hyperechoic or polycystic kidneys. And our autosomal recessive and autosomal dominant polycystic kidney disease are the most common ciliopathies. So multicystic dysplastic kidney, it's one of the most commonly seen genitourinary abnormalities. You may hear it referred to as renal cyst dysplasia, dysplastic kidneys, Potter type 2. This is when you see bilateral multicystic dysplastic kidney. And then it's one of the congenital abnormalities of kidney and urinary tract. So you may hear it referred to as that. So essentially the definition is non-communicating cysts in dysplastic renal tissue that is usually non-functioning. 75% are isolated, meaning you're not seeing other findings along with them. 80% are unilateral. They're more common on the left than the right. 90% present with increased renal size greater than the 95th percentile. So important to refer to that chart on the prior slide for kidney size in the sagittal plane. And then 94% of all cases are detected antenatally. So like we're really good at finding this on ultrasound. When we are looking at the epidemiology, unilateral MCDK is 1 in 4,300 live births. Bilateral is less common, 1 in 10,000 live births. It is more common in males than females.
It really sounds more common here, like, you know, I guess because we're a referral center, but that would say less than 1 a year. We see more than one.
Some studies said 1 in 4,000, but that was like the lowest I saw.
Right.
Yeah.
Yeah.
So
I see many of these.
yeah. Dr. Ryman reviewed embryology for the GU system very recently, so I'm not going to belabor this too much, but I just wanted to kind of do a quick 1 slide refresher. So formation of the urinary system begins in the 3rd week of gestation as pronephros in the cervical region. And then this leads to the development of mesonephros. And the mesonephric duct forms the ureter and collecting system of the renal pelvis, which makes urine by 16 weeks. This figure on the left here shows that the ureter bud, which is the red, arises from the distal mesonephric duct, which is blue, close to its origin at the cloaca, and grows cephalad to meet the renal blastema, which is what's up here labeled K. And this eventually gives rise to the renal collecting system. So the connection of these two structures triggers the release of signaling substances or growth factors called GDNF. And so there are a number of these growth factors. And essentially these growth factors, we've seen a few of them, induce the branching and proliferation of renal tubules. So this figure on the right shows how the disconnection between the bud and the blastema leads to lack of release of these signal factors and therefore lack of branching and proliferation of the renal tubules. So your collecting system is affected. And so in MCDK, there may be severe atresia or complete disconnection between the blastema and the bud. And so bud branching signaling factors are never released and the nephrons fail to develop properly, appropriately. So there are multiple theories as to what is the underlying etiology. Again, the one that I just reviewed is the Gruder-Bud theory. So essentially, you have this atretic bud and it doesn't signal the mesonephros and it leads to abnormal branching with loss of nephrons and essentially formation of aberrant structures such as cysts, cartilage, stromal expansion. There's also a theory regarding early obstruction. And so maybe there's an early ureter obstruction, which leads to dysplasia. And then because of that, the metanephron doesn't form nephrons. There's infectious theories. So maybe there are some viruses that are involved, enterovirus, cytomegalovirus, adenovirus. Interestingly, when amniocentesis has been performed, in MCDK cases, in cultured 1 to 3% of those cultures come back positive for infection. There's some thought of maybe certain underlying comorbidities increase the risk of this, like diabetes, for example, or perhaps certain drugs like ACE inhibitors, but these are kind of less commonly agreed upon theories. So when we're talking about the sonographic findings of unilateral MCDK, you can have cysts of variable shapes and sizes, and they do not connect. So like Dr. Alquali said, this is like really classic for this finding. You're seeing variable shapes and sizes.
MFM oil, maybe they show you a picture like that.
Well, we're gonna look at some pictures in a second so we can have it ingrained into our brain. You have little to no normal renal tissue. The renal pelvis is not usually seen. You have increased echogenicity of the renal parenchyma between cysts, and this is secondary to dysplasia, fibrosis, cartilage metaplasia. You have loss of the typical reniform shape of the kidney. Renal artery flow may not be detectable, or it might be. Usually you're not seeing any evidence of obstructive nephropathy in the setting of a unilateral MCDK. And then you have compensatory hypertrophy of the contralateral kidney. And so the renal length is typically more than 2 standard deviations of the mean. If you have this compensatory hypertrophy of the contralateral kidney, it's actually associated with good prognosis. And we'll kind of get into that later. You have a normal bladder and often normal AFI.
So basically, I just want to make sure. So really, each one of you need to memorize these ultrasound findings. Cysts that are small, cysts that are large, throughout involving the entire kidney. And very important is the echogenicity. What you think is really a normal kidney is actually too bright, as Keely have mentioned. Remember why? Because there's dysplasia and fibrosis basically in that area. And that is why it looks white.
And that is why you don't have any functioning.
Exactly.
It's not.
Exactly. So even though you see renal tissue, that is not a normal renal tissue that is going to function. And really that is the most important conclusion for the multicystic dysplastic kidney.
So this is a sagittal ultrasound that shows a left MCDK with multiple cysts of variable sizes, replacing the normal renal parenchyma. And this is on the left side. And as we talked about, the left side is the much more commonly affected side. This is another image that shows MCDK. You're seeing this echogenic parenchyma, so brighter, and you're seeing multiple non-communicating cysts of variable sizes between 2 indicators here. This is a 22-week fetus with left MCDK. The kidney again is replaced by multiple cysts of variable sizes, and you're seeing that the parenchyma is echogenic. And again, it's because it's fibrotic and dysplastic and non-functional. So color Doppler shows no flow within the cyst as it did in our case. But sometimes you can see a renal artery that is supplying the dysplastic kidney. So what about bilateral MCDK? Well, you're going to see bilateral cystic kidneys. You're not going to see a fluid-filled bladder. You're going to have oligohydramnios or anhydramnios, which then leads to pulmonary hypoplasia, small chest, and also joint contractures, et cetera, from your lack of amniotic fluid surrounding the baby. And so here's a picture of bilateral MCDK. You're seeing both kidneys are replaced by diffuse cystic changes.
What view is this? It's first or?
No, I think it's sagittal-ish. Coronal-ish. I think it's coronal, because you're seeing both. It's definitely not
Yeah.
transverse, but I think it looks coronal-ish.
Hmm.
Interestingly, this is the adrenal gland. And you're seeing that the adrenal gland is, quote, lying down in your empty renal fossa. And so in this case, you know, you have both kidneys affected, but this kidney is a pelvic kidney.
It's displaced.
It's displaced. And this is like a classic finding in the setting is the lying down adrenal.
Mhm.
This is that same case revealing that there's clearly no obvious fluid around the baby. And you can see that the heart looks enlarged, so cardiomegaly. And this is secondary to the development of pulmonary hypoplasia, secondary to the lack of fluid around the baby. And so of course your cardiothoracic ratio is elevated. But it's not truly cardiomegaly, it just looks that way because of how. Stop letting me advance. So when we look at the natural history, we're going back to unilateral, more common, natural history of unilateral MCDK. So wide range, but 19 to 74% involute over 9 months to 10 years of life. The majority involute within the first 18 months of life. Multicystic dysplastic kidney that has a size of a larger size is less likely to progress to complete involution, but may partially involute. Like we kind of mentioned earlier, a large majority of them have compensatory hypertrophy of the contralateral kidney, which is good for prognosis, so 92%. 20% have reflux, which increases the risk for infection. So we'll talk about it later, but it's something that's monitored. And then there is a risk of hypertension. It's a wide range depending on the study, anywhere from less than 1 to up to 17%. This can be resolved with a nephrectomy, but we'll kind of get into how that's rarely done. And then there's a rare association with Wilms tumor. This is incredibly controversial. Recent data actually say the risk is way less than 1%. And the thought is that prior studies like decades ago that had this finding and thought it was Wilms tumor, really it was pre-good ultrasound. And so a lot of these diagnoses were being made on like physical exam and they're palpating this mass and assuming Wilms tumor. And so that's where some of that data comes from. But anything recently, there was a review of cohort studies that looked at studies between like the late 1980s to the 2000s, and it essentially found a 0% risk for Wilms tumor development. So that you can just give that reassurance to the patient.
The patient did ask, to go back to that slide, like how long does it take to involute? So this is amazing. Like you got that data for her, which is something patients would like to know.
You are 40 to 50% of the time going to see a contralateral renal anomaly. So we're not talking about a bilateral MCDK, but we're seeing another renal anomaly on the other side. And so you may have UPJ obstruction, renal agenesis, contralateral renal hypoplasia, reflux, Obviously, in this case, we saw pyelectasis. Some studies even set up to like 75%, you'll have a contralateral, some sort of contralateral finding. Also important to note that you can see MCDK with different renal variants. And so pelvic kidney, which we saw in a prior image, when we talked about the lying down adrenal, horseshoe kidney, duplicated kidney. And so there are also associated extrarenal anomalies, and these are seen in up to 25% of cases. Some studies quoted up to 35%, but most commonly cardiac, central nervous system, GI, and vertebral and skeletal malformations. So you're obviously always looking, when you see one thing, you're always looking for anything else that may appear abnormal.
So if CHOP ordered an MRI, which one of these you think would be a good thing to look at by MRI? Maybe more so by ultrasound. Typically, honestly, I don't order the isolated multicystic dysplastic kidney MRI because we can do an echo and we can look extensively at the heart.
Right.
The GI by ultrasound also is great. Vertebral and skeletal, probably the ultrasound too. So the only thing is the central nervous system, but how much, we can look for ventricles, corpus callosum, posterior fossa. So
If you're not seeing anything concerning there, what is?
exactly. So I'm just teaching you so that, when you graduate from here, are you gonna order an MRI on your patients with this similar finding or not? Yeah, but it's nice to know about these associations.
They did an MRI at CHOP?
They're going
Yes.
to, they have not yet.
Would you have done an MRI?
No, I usually don't do it.
I don't.
They have so much data there and they don't publish it. No.
Yeah.
But that's a perfect paper they should publish.
Yeah.
We do an MRI, most sick kidney, the extra incidence of anomaly, not
And
diagnosed.
that's the yield, the additional yield.
50%, whatever.
Yeah.
So importantly, you see this finding and you now have to counsel the patient on it. What is the prognosis? That's what patients care most about, right? How is this going to affect my baby? And the reality is if it's unilateral MCDK, it's an excellent prognosis. And it really, overall, the prognosis depends on the health of the contralateral kidney. And so, for example, if the contralateral kidney is hypoplastic, this will increase the risk of renal insufficiency. But if that contralateral kidney is normal and functioning normal, then it's an excellent prognosis. And just of note that the involved kidney, so the kidney with MCDK, is non-functioning in more than 90% of the cases.
Could I stop you there? I was going to ask at the end, but going back to that last statement you made, does it depend, because, does it depend on the number of cysts, or, because the way you're ending it, it's pretty bleak. Like, you have a multicystic kidney, it doesn't work. And, you have to hope that one is okay. But historically, 10, 20 years ago, we used to cancel, this kidney may not work, but, you're going to have tests, post delivery to assess. It looks like the most recent data is pretty bleak.
Yeah, and from my understanding, like the counseling really should be like, this is a non-functional kidney.
All right.
And you obviously have cysts that have taken a good portion of the kidney, but then even in between that what should be normal renal parenchyma is just not there because it's dysplastic and fibrotic, so it doesn't function. And so even if you're seeing what looks to be somewhat like a kidney in between all of these cysts, it's usually non-functional tissue.
Yeah.
And so you can pretty confidently tell the patient that this is not going to be a functioning kidney. Which is why when we see a contralateral finding in the other kidney, it really changes the prognosis because now you have no well-functioning kidney.
Yeah.
What was the fluid like on the case you presented?
Normal.
And there was also fluid in the bladder,
Mhm.
right?
Yep.
But both the kidneys looked like they were affected.
No, the one just had pyelectasis.
Okay, got
It was unilateral. Yeah, which you will see in normal bladder, normal fluid in unilateral. Unilateral.
it. Okay, I was like,
Yeah. So bilateral is almost always fatal. Renal failure and pulmonary hypoplasia combo is a bad combo. You should certainly discuss termination as an option in these cases. And if the patient decides to continue on with pregnancy, you're obviously monitoring these even more closely than you would a unilateral. So what is the prognosis if you have a unilateral MCDK with a contralateral renal anomaly? So it's not bilateral MCDK, but you have something else going on in the contralateral kidney. Well, it depends on what that anomaly is. So if it's severe, then it's often fatal, much like bilateral MCDK. But if it's mild, it's often a good prognosis. We're going to review this article, predictors of poor neonatal outcomes in prenatally diagnosed multicystic dysplastic kidney disease, published in the Journal of Perinatology. It was a retrospective review of prenatally diagnosed MCDK for about a decade at Stanford's Children's Hospital. It included 53 cases of prenatally suspected MCDK. The aim was to characterize clinical outcomes in prenatally diagnosed MCDK and assess prenatal factors associated with adverse outcomes. And their primary outcome was death or need for dialysis among live-born infants. So we started.
That's an important study.
Yeah,
Very
it's
important
great.
study.
Um,
Really, it should be part of your counseling. Yeah.
So it includes 53 patients, as I said, 2 ended in fetal demise, 2 terminated, 87 live born, and then 87%, sorry, and then 6%, it was thought to be MCDK prenatally, but then postnatally was found not to be. Of the patients that were presumed to be MCDK prenatally and then confirmed postnatally, 83% of those survived, 17% didn't survive, and we'll get into these numbers a little bit more. 4 of those died before 24 hours, and then 4 died after 24 hours. So this table looks at the predictors of poor neonatal outcomes in prenatally diagnosed multicystic dysplastic kidney. Again, our survivors are about 83%, our non-survivors about 17%. So survivors, non-survivors, anhydramnios, bilateral MCDK, and extrarenal anomalies were significantly more common among the non-survivors compared to survivors. And so there was no difference in median gestational age between the survivors and non-survivors. So initial presentation was 25 weeks for the survivors, 26 weeks for the non-survivors. Amniotic fluid was normal in 95% of the survivors, but only 38% among non-survivors. Contralateral renal anomalies were diagnosed in 7 of the survivors, so 18%. They listed what those specific cases were. So there were 5 cases with hydronephrosis, 1 case with just increased echogenicity, very vague, and then 1 case of renal simple cysts. In comparison, all 8, so 100% of the non-survivors had a contralateral renal anomaly, which included 2 with bilateral MCDK, 1 with bilateral echogenic kidneys, 1 with an ectopic fused kidney, 1 with an echogenic kidney with a uretocele, and 1 with renal agenesis, and then 2 with hydronephrosis.
How many had extrarenal malformations?
So
Among those who
extrarenal,
died,
0% with the survivors, but 63% with the
5 out
non-survivors.
of 8 though, okay, but like 4 of them were bilateral anyway.
Exactly.
Okay.
Exactly. It's crazy. Okay. This is looking at non-survivors and looking at our right kidney, left kidney, amniotic fluid, and what the postnatal evaluation was, and then their time of death. And so, as I kind of mentioned previously, of non-survivors, 4 passed within 24 hours of life, and this was due to pulmonary hypoplasia, pneumothorax, and hypoxia. And then 4 died after 24 hours of life. This was due to cardiac failure and post-surgical cardiac complications. 1 had trisomy 18 and died at 2 months of life from aspiration pneumonia. So now we're going to get into the genetics of MCDK. So some cases of MCDK have a known genetic cause. 7 to 14% are thought to be associated with chromosomal abnormalities and syndromes. This risk is increased in non-isolated cases. It's really hard to think. Etiologies include copy number variants and single gene disorders. The most frequently detected variants are 17q12 and 22q, 11.2. Single gene disorders associated, there are a number of them, but these are just a few. Branchio-otorenal syndrome, renal calabomus syndrome, renal cyst and diabetes syndrome. This involves MODY, interestingly, not M-O-T-I, M-O-D-Y.
Right.
Yeah. And the thought is there's defect in genes involved in that GDNF. So if you remember back to that embryology slide, we were talking about the appropriate signaling that's happening between the bud and the blastema. It's the genes involved in this where things go awry, and there are a number of associated genes, a few of them. So what about chromosomal microarray? There was a study that looked at chromosomal microarray in 30 fetuses with MCDK. And it was reported to detect 6 pathogenic copy number variants. So there is thought to be about a 50, based on this, about a 15% detection rate in isolated MCDK, and a 20% in MCDK that has extrarenal anomalies. Another study showed that the use of CMA may improve detection rate by an additional almost 17% in patients with MCDK and other congenital anomalies. So certainly, if you're seeing other things along with it, you should.
Can you go back to that slide? So 6 pathogenic copy number variants. Okay.
So a small number that we're basing this off of, but
Mhm.
it obviously adds information.
Yeah. So always, anytime you see an isolated risk, it's less than when you have, associated extrarenal abnormalities. We know that. I think it's nice. Maybe you can email that paper to us, and I can email back to the students. It's always nice to know which copy number variant changes.
Yeah.
I know a huge genetics paper with the multicystic kidney was submitted to Dr. Bergella's journal. I think it's under like review right now. So once I have that, it's from China. I can also send to all of you guys, because it also really, it's one of the most extensive study that has been evaluated the genetics of kidney diseases. And okay, got it. So at least we can say 15%, maybe up to 20%, which is 15% is really higher. Because the general teaching, a microarray is going to give you an additional lead of around 6%. So, but this is very, very interesting. But again, the number was 35. That's an excellent number given how infrequent this disease is too. Great.
We don't have a lot.
Yeah.
What about a role for whole exome sequencing? So it's important to consider if there are additional anomalies or a family history of a specific syndrome. Certainly, remember, chromosomal microarray is not going to detect your single gene disorders. So 11% of fetuses with MCDK had genetic variants on whole exome sequencing after a normal karyotype in chromosomal microarray. So again, I thought that was pretty good.
Yeah. And this is like in line with what, an exome in general for an isolated finding. Oh my God, it's published already.
Was that the one?
Yeah, this is the one. Yep. So for the students, if you want to write down the author's last name is Huang, H-U-A-N-G. First name will be in R-U-I-B-I-N. I'll download and I'll send to you.
I'll send it to you.
I sent to me,
I'll send
yeah.
to everyone.
Send to everyone. And basically, that's really one of the great papers about them. You're going to be shocked, the single gene etiologies for these genetic etiologies. So it's really, I think this paper is a breakthrough. It's just published in the Pink Journal I see here now. Great. Okay, wonderful. Thank you.
So antenatal management. Obviously on ultrasound, we're evaluating the contralateral kidney. We're looking for other anomalies. We're offering genetic counseling and diagnostic testing. This is especially important if other anomalies are present or it's a bilateral presentation. Getting a fetal echocardiogram, and then follow-up ultrasounds. SMFM states 32-week growth to assess growth, obviously, AFI, contralateral kidney, but looking through studies, most support serial ultrasounds.
Oh,
and
yeah,
not
absolutely.
not
Uh-huh.
waiting that long. It's incredibly important to follow the AFI as this reflects your contralateral renal function. Some studies reference considering an MRI if it's an atypical presentation or you're unable to adequately evaluate secondary to oligohydramnios or anhydramnios. So if you just aren't able to see, then that could be helpful. Certainly consultation with pediatric nephrology and neurology, especially important if there's anomaly in the contralateral kidney. And then what about antenatal testing? There's really insufficient evidence for this. And then delivery recommendations just based on usual obstetric indications.
So the antenatal testing, honestly, it also depends if you have a genetic etiology. And unfortunately, we, as MFM guidelines were written, and they didn't address, let's say, if a baby has, a deletion or a duplication, do we need to do NSTs for them? Now, we all know that fetuses who have a genetic change are at an increased risk of stillbirth. So it will make sense to do fetal testing for them. Let's say you diagnose a copy number variant, in like 15% of the cases. Otherwise, really, antenatal testing is driven, by the amniotic fluid.
I just had to throw this in here because I thought it was
Yeah.
pretty crazy. So this is just a sagittal MRI that shows MCDK. So when our patient gets her MRI at CHOP, this will likely be what it looks like. You can see that there's normal amniotic fluid, which tells you that the contralateral renal function is up to par. Again, really, we should only be considering MR, or most people feel we should only be considering MR when we have fluid that's not evaluating us or not allowing us to evaluate. So it's like technically limited because of that. This is a coronal MR that shows MCDK and a contralateral normal kidney.
Yeah, and you see it's much bigger too,
Much
right?
bigger.
Yeah.
Much bigger. What about postnatal treatment? So neonatal imaging, baby's gonna get renal ultrasound to confirm diagnosis after birth. Will undergo a voiding cystourethrogram to evaluate for reflux because there is that association. And then likely we'll eventually get an isotope renal scan to assess overall function. As far as surveillance, usually ultrasounds every 3 to 6 months for the first couple of years of life. Some people say to continue those yearly until age 4, monitoring blood pressures, urinalysis for proteinuria, and kind of following serum creatinine. And then you're doing a nephrectomy only for complications at this point in time. So you have an enlarging mass that's impacting respiration or feeding in the neonate. You have hypertension, Wilms tumor, but we kind of discussed that that's really been shown to not be associated, or baby is having recurrent infections. So essentially postnatally, it's conservative management and follow-up in the vast majority of cases. And so you can reassure patients with this information. This is just a little flow chart that suggests an algorithm for following them postnatally. And so you diagnose your MCDK, you get your postnatal ultrasound. They suggest renal ultrasounds at 12 to 24 months old. To check for involution of your dysplastic kidney and also evaluate the contralateral kidney. If the contralateral kidney is growing well and has no other abnormalities, then annual blood pressure checks and urinalysis for protein in the urine, and then get an ultrasound again post-puberty. Again, indications for nephrectomy. This used to be very controversial, but now is much established as uncontrolled hypertension, enlarging mass, et cetera. We just talked about. So just briefly want to talk about differential. I'm going to preface this by saying each of these could be its own lecture. So this is not at all meant to be. I loved this. I found it very, very nice. So this should kind of sum up your differential here. And so if you're seeing a solitary renal cyst, you're thinking a single cortical cyst is your most likely diagnosis, but then have a list of other things in your differential. If you're seeing multiple unilateral cysts, you should be thinking MCDK, but again, there's a list of a differential, which we're going to get into.
Are you gonna go for,
Gosh.
are you gonna go to the differential for each one? Because it's really important, because sometimes I would see like a single cortical cyst in the kidney. Can we, or at least read them loud so that everybody can? Yeah.
Yeah, like
Yeah.
read the differential for each.
Yeah,
so
are you gonna go into each one of
I'm
these?
not, I don't have
Oh,
enough
no, no,
time
I
to go
think this
into
is
each,
important,
but
actually.
Okay.
Yeah, is that okay? with
Yeah,
everyone? We still have
absolutely.
time.
it
Yeah,
is.
10:14,
It
yes.
is small, okay. So for our solitary renal cysts, again, most likely diagnosis is your single cortical cyst, but then you're also thinking about segmental multicystic dysplastic kidney, extrarenal cyst, so maybe it's an ovarian cyst, maybe it's not the
That's
kidney
it.
at all.
Mhm.
Dilated dysplastic upper pole of a kidney, a cystic tumor, or the beginning of polycystic kidney disease.
Mhm.
When you're seeing multiple unilateral cysts, like we did in this case, the first thing you're thinking is MCDK, most likely diagnosis, but again, could be the start of polycystic kidney disease. It could be cystic dysplasia. And then it could be unilateral beginning of some other cystic disease, which is very broad. If you're seeing bilateral cysts and or hypoechogenicity, but not seeing oligo, you're thinking bilateral cystic dysplasia. This can be with or without obstruction, but your differential includes a wide array: autosomal recessive polycystic kidney disease, autosomal dominant, your HNF1 beta associated disorder, which we're gonna talk about all 5 of these that are listed. Corday-Bedell syndrome, Meckel-Gruber syndrome. There are a number of other genetic syndromes, which I list at the end, which is not even all encompassing. Tubular dysgenesis, metabolic diseases, drug toxicity, and ludo. And then when you are thinking about bilateral cysts with oligo, you're thinking autosomal recessive polycystic kidney disease syndromes or bilateral cystic dysplasia, but your differential includes everything that we just went over on the prior differential.
Is there a particular drug with drug toxicity for the bilateral cystic dysplasia?
That I do not know.
Me too.
So you can't really distinguish bilateral multicystic from autosomal recessive polycystic without genetic testing, is that right?
No, you can, how can you?
But what if they both present with?
Isn't there cysts in the brain too that you can have, right? You can have like cysts in the brain for autosomal dominant.
But most of them in utero are not gonna have it, so it's really the ultrasound, so now you're an expert. You're gonna see the kidney, tiny cyst, big cyst, you're gonna see echogenic material in the center. Autosomal recessive, it's diffuse, it's all,
Why?
it's gonna be whitish.
We're gonna look at it.
Oh, thanks. I'm stealing your thunder, Dr. Robinson.
It's okay.
Yes.
So Ludo was on our differential. Dr. Ryman had an excellent fetal therapy on this a couple weeks ago, so I'm not gonna go into that. But that should be on there. Obstructive cystic dysplasia is also called Potter type 4. This is the most common congenital GU anomaly that leads to chronic kidney disease in children. The findings are progressive in utero, so essentially cysts develop over time. It often presents in the late second or early third trimesters. So you see urinary tract dilation as your first finding, then you're going to see increased renal echogenicity, then you'll see small peripheral cysts, and then these turn into larger cysts. So your sonographic findings, your renal echogenicity is going to be more than your liver echogenicity. Again, you're seeing these peripheral cysts that eventually start small and then become larger. And then you see variable urinary tract dilation and amniotic fluid volume, but urinary tract dilation is typically your first finding with this. And then just important to know that end stage findings. So when you're looking at it, when the cysts are large, you know, in the third trimester and they've progressed to that point, it can mimic MCDK, where the kidney is essentially replaced with cysts. And so this is a patient who initially presented with the fetus had bilateral renal pelvis dilation. You can see that both left and right are dilated. And then you can see that they're subtle, but you can see that there's some subcortical cysts, suggesting that the obstruction has potentially caused some amount of renal dysplasia. And then in the third trimester, you re-image the same fetus and you're seeing these cortical cysts, and they have certainly increased in size and number, and more cysts have formed. And so this progression is very, very typical. But obviously in our case, we saw this early on, 20-week anatomy.
Mhm.
So that is how
And
you.
remember how the cysts they were displayed and how the echogenicity really, it's different.
So if you have someone come in for a 32-week anatomy and you see this, it's gonna be really hard to say.
That's just, you should have seen it at 20 weeks.
Right. But if you're seeing the patient for the first time, you won't really be able to decipher between these two diagnoses. Okay, again, this could be an entire presentation on its own, but just broad strokes. Autosomal recessive polycystic kidney disease. This is the most common ciliopathy diagnosed in fetuses. The incidence is 1 in 20,000 live births. The mutation is in PKHD1, which is on chromosome 6p21. This is the most common cause. There are a number of other causes, but this is the most common. So this gene encodes fibrocystin and polyductin, which is involved in collection duct and biliary differentiation. So your sonographic findings, you're seeing enlarged kidneys. They're 4 to 15 standard deviations above normal. You're seeing hyperechoic kidneys with poor corticomedullary differentiation. You're seeing oligo or anhydramnios. Cysts are often smaller than those seen in MCDK. And then can develop into larger cysts in the 3rd trimester. This is associated with end-stage renal disease and hepatobiliary disease, so much different prognosis than our MCDK. High morbidity and mortality, the perinatal mortality is quoted to be about 30%, but of survivors, 82% are alive at 10 years. However, 50% of those need renal transplant by the age of 20. And so again, a case where you should be offering termination. So the patient has that.
So this alone, if we can go back, so this is we call this like ARPD, autosomal recessive polycystic kidney disease. You really need to know the gene, PKHD1 for this one, okay, dear? And then again, as Vincenzo have mentioned, it's going to be enlarged, a little bit enlarged, it's going to be echogenic kidneys. You're not gonna see the cysts. The cysts are like almost microscopic. They're gonna see like tiny dots. So it's unlike the other disorders. So, and typically with this disease, there's going to be, you know, anhydramnios very early in pregnancy. And these are always, I've had a few of these in my career, and they're always very, very sad cases. And as you mentioned, I always remember it's a ciliopathy, because this is something you will also get on your board exam. So it's basically the cilia, and that's why the liver may be affected. That's why the brain also. So basically, very high morbidity, and many times, like these babies are born, they're gonna need dialysis immediately if the family desires all measures, and then you know the babies are put on a transplant list, basically.
And this is a coronal view that shows bilateral enlarged hyperechoic kidney and a fetus with autosomal recessive polycystic kidney disease. So again, like Dr. Alfali said, you're not seeing that, you know, cystic appearance that we're seeing in MCDK. And this is just a coronal color Doppler. It's a 32-week fetus that again shows very enlarged kidneys. The medullary portion of the kidney is more echogenic than the cortex. And so medullary.
Yeah, and you can see the whiteness, right? The whiteness. And you don't see this is like just the anal pelvis, the black.
And this is, I mean, these are huge. Look, this is like pelvic bone and like
Absolutely.
lower edge of the rib. Like
Yeah,
this
yeah,
is like
yeah.
very large.
Yeah, people worry about dystocia at delivery for these babies. That's great.
Autosomal dominant polycystic kidney disease, most common inherited kidney disease. The incidence is 1 in 400 to 1 in 1,000. It's most commonly secondary to a mutation in PKD1. This is 85% of cases, or PKD2. PKD1 encodes the protein PC1, and PKD2 encodes the protein PC2, which when defective can lead to disruption of calcium signaling, and formation of fluid secretion, cyst formation, and vascular sclerosis. Patients with PKD1 progress to kidney failure 20 years earlier than PKD2. And so you're actual mutation is important in the prognosis. There's a significant phenotypic variability in disease progression and complications. 10 to 25% are caused by de novo mutations. So sonographic findings, important to note that less than 1% present in utero. There were some studies that said that was a little larger number, but it's a very small percentage that are going to present in utero. But if it does, you're going to see enlarged kidneys that are not as enlarged as your autosomal recessive polycystic kidney disease, only 1 to 2 standard deviations above the mean. Hyperechogenic cortex, and then cysts are seen in about 15% of the cases that are diagnosed prenatally. It's usually adult onset, which is why you don't see it prenatally, but you can see it manifest in childhood in some cases.
So on your board exam, I think most of the students had to leave because they have other commitments at 10:30. So on your board exam, please, you know, if they tell you enlarged kidneys, do not say the autosomal dominant polycystic, because this is very unusual. If it's going to be that inherited genetic one, it's the ARPD, okay, not the ADPK, not the AD one. So just remember that. And then in the adult life, it's always nice for you if you want to read about it. They count like how many cysts, they do a kidney ultrasound on them, and then how many cysts do we have as adults. I forgot the cutoff, I think more than 4 or something. So yeah.
Well, I can kind of breeze through a little faster
Yeah.
here.
No, you're good, you're doing great. This is
Okay. I
fantastic.
just have a few more slides. Hepatocyte nuclear factor 1 beta nephropathy. So variants in the HNF1 beta lead to multisystemic presentation with congenital anomalies of the kidney, urinary tract, pancreas, MODY type 5, electrolyte abnormalities, and genital malformations. This is inherited in an autosomal dominant manner. However, there's a wide variability in expressivity and penetrance. So HNF1 is also known as HNF homeobox B or transcription factor 2, and it's encoded by the HNF1B gene on chromosome 17q12. It's a homeodomain containing tissue-specific transcription factor that's important in nephron development. And so heterozygous mutations or complete deletions of HNF1 beta and adjacent genes can lead to HNF1 beta nephropathy. And so your sonographic findings are bilateral hypogenic kidneys and unilateral or bilateral renal cysts.
And what you need to know about this gene is like kidney, pancreas. So, okay, you have kidney, but we also have diabetes on top here. So I have to give you the pearls.
No, it's good.
This is how we remember stuff.
Another ciliopathy with multi-system involvement. There, we could do like a whole lecture on ciliopathies, obviously, and each one could be its own lecture. But incidence is 1 in 100,000, autosomal recessive, multiple genes involved, more than 20. It's most commonly secondary to mutations in BBS1 and BBS2-1. Sonographic findings are again enlarged kidneys. They can be unilateral or bilateral. You may see ectopic, duplex, or horseshoe kidney, homogeneous renal parenchyma, post-axial polydactyly. So if you're seeing that with kidney, you should be thinking this, normal AFI. And Meckel-Gruber syndrome, this is considered the most severe ciliopathy. The incidence is 1 in about 13,000 births, autosomal recessive. Your sonographic findings are enlarged cystic kidneys, usually bilaterally. The cysts often appear earlier than they do in autosomal recessive polycystic kidney disease. They cause massive swelling of the abdomen, similarly to autosomal recessive PKD. You're seeing polydactyly, post-axial, and central nervous system malformations. And so often in occipital encephalocele. And so if you're seeing polydactyly brain and kidneys, you're thinking this. It has a high mortality rate in utero or immediately after birth. And this is secondary to pulmonary hypoplasia, kidney failure, and the encephalocele. And then other syndromes that we're not going to touch on are listed here if you're interested in reading up more. But obviously there are a number of syndromes that can present with renal cysts. And just real quick for the fellows, tips and tricks for anechoic structures. When you're trying to decide, is this renal cyst or is this hydronephrosis? So if they connect centrally with the renal pelvis, you're thinking hydronephrosis. And so these are your obstructive etiologies. If they don't connect with the renal pelvis or with each other, you're thinking these are discrete cysts. So you're thinking your MCDK, cystic dysplasia, et cetera, et cetera. So in summary, MCKD is one of the most commonly seen genitourinary abnormalities. The prognosis is dependent on if it's unilateral or bilateral, if there are associated abnormalities in the contralateral kidney or extrarenal anomalies. If there are extrarenal anomalies present, there's certainly an increased risk for genetic etiology. Isolated MCDK has an excellent prognosis and rarely requires surgery postnatally. You should refer all patients to genetics and always consider the differential when you encounter cystic kidneys.
I love it. Yay.
Great job, Keely. That was awesome.
That's great.